thank Dr. Klinger, and that was a great lecture by Trish to kind of give you an idea of what's going on with physical therapy and how we can help you. I'd like to kind of tell you a little bit how we kind of put it all together in physical therapy today. What we do in our clinic is try to develop protocols for people throughout the country, because I think that's really the next level of what we need to do for EDS, so everybody's kind of doing similar stuff and we're not having this segmented treatment protocol. So that's what we're trying to look at in physical therapy, at least in our clinic. Our objectives today, I'm just going to basically tell you what we do in our clinic and how we look at everything. And we're going to talk about a little bit of common dysfunctions. The first thing I always talk about is we need to have a team approach. A physical therapist, there's no one doctor that can treat EDS. We need to have a group or a health care team. We all do different things, and I'm just a small part of this team. What physical therapy cannot help, and this is what I basically tell everybody, is this is why I need a healthcare team on my side. And fortunately in Rhode Island we have a great healthcare team. Things like POTS, mast cell, GI issues, food allergies. For me as a physical therapist, if these are not being treated, it'll cause global inflammation throughout the body, which will make it much more difficult for my patients to actually get stronger. A lot of the things that we look at when people come in and they say they're having an EDS day, I tell them it's usually some kind of systemic response that's going through the body that day, which is inhibiting the muscle strength to hold their joints together. And again, my job as a physical therapist is to work on subluxations and strengthening those muscles around the joints so they don't sublux. We also have neurological issues which impede muscle strength as well. That's where Dr. Klinger comes in to help us out for those certain situations. So what do I actually do as a physical therapist, and all physical therapists do? We work on joint pain due to hypermobility. And again, we talk about with our patients all the time, you know, we try to keep things simple in life. Everybody's really going to the cellular level, and I kind of want to look at it more globally of what you need to do with a patient. And, you know, we talk about why does a joint sublux? And I tell everybody it's a simple math problem. When the external forces of the environment are greater than the muscular strength, the capsular strength, and the actual ligamentous strength of the system, the joint will sublux. If it's less, it doesn't. So our job as physical therapists is to strengthen the muscle around it, to actually allow that joint to absorb more forces, and also to educate the patient on how to decrease those external forces. And again, for the EDS population, because they're so weak and they have a lot of joint laxity, when I talk about external forces, I'm talking about maybe carrying groceries and stuff like that. I'm not actually talking about, you know, going to lift 200-pound weights or anything like that. So how we do this, we work on posture and gait. So when we work on posture and gait, what we're doing is we're actually decreasing those forces. So when someone has a poor posture or a bad gait, they're going to have increased stress on their joints. So we need to work on that. We work on endurance, strength, balance. And the most important thing is I see my patients a couple of times a week for months on end. Communication with other healthcare members, that's the most important. If we're seeing a change in status with our patients, we need to actually help and call the other members of our healthcare team, especially if it's something that we don't work on. And also we need to educate our patients on how to live with EDS. This is a chronic disease. This is something they're going to have to live with for the rest of their lives. So to teach them how to figure out what to do and teach them self-corrections, teach them things on how to live their lives with this disease. It's not like a total knee that after they're rehabbed, we don't have to worry about it for the rest of their lives. This is something they're going to deal with forever. How do I evaluate a person with EDS? First thing, I just do a quick systems review. What I'm looking for is what other members of the healthcare team I need to pull on to help this patient. And then we have, like I said, a great referral system, and we refer them to those proper people. Then what I do is when someone comes in with pain and they have pain everywhere in the body, it becomes overwhelming for a clinician. So what I do is I actually split the body into 3 sections to make it a little bit easier. I look at the SI joint, the low back, and the hips. Then I evaluate the mid-back, the ribs, shoulders, neck, elbows, hands. And finally, we look at the feet, the knees, as well as we look at gait and balance. This kind of makes it a little more palatable when we come in and the person's trying to figure out, what's really going on. The most important thing with these patients is you need to educate them on everything that you're going to do, because they're going to have a little bit of, they usually have a lot of problems with the healthcare system in general. So educating them will help calm them down and kind of buy into the system of what we're going to do to help them out. We also talk with the patients. We get them involved in what their treatment plan is going to be and kind of explain how the whole thing works. And I think that's important to get the buy-in right away. How do I treat a patient with EDS? And basically, it's our entire clinic. We treat about 100 EDS patients a week in my clinic. We also have people flying from all over the world to see us. So we really work hard on trying to educate patients a lot. We do manual therapy, which Trish did great on, so I'm not going to really go over that. We also work on strengthening protocols in our clinic to help strengthen each individual joint. The most important thing when we look at strengthening protocols, we want to make sure that the actual exercise strengthens that joint or the muscle that we're trying to strengthen and also protects other joints. So my biggest example, as I tell everybody, is one of the staples in EDS is side-lying hip abduction, where a person lies on their side, lifts their hip up and down. That's a good strengthening protocol for the gluteus medius. Basically what I tell everybody is that's great in the EDS population. It subluxes their shoulder when they're laying on it. So great for the hip. If you have a script for the hip, then you can get a script for the shoulder neck. So that's great to keep them coming. So we have to look at certain exercises and determine, is this good for the entire body? And again, my clinic is big on things like self-corrections and family education. If they can fix the thing, we teach them how to fix it. So when a patient comes to me and if they have an SI joint dysfunction, like Trish was talking about before, we fix it the first couple of times, but then they come in and we actually videotape how to fix the SI joint and have a family member actually do it at home. Because again, they're going to have a problem with this for their entire lives, so it's better to have someone at home fixing them than having to come to me all the time. So we really try to make them as independent as humanly possible with what we can. Some things they can fix, some things they can't, but we try to, whatever they can fix, we try to fix. Common issues in EDS, I always say, preface it with all EDS patients are unique with their own specific issues, which makes this population difficult to evaluate and treat. Now, there are some similarities among the EDS population that are different from the non-EDS population. I'm going to go over those now. I always talk about, in my clinic, we talk about KISS, keep it simple sometimes. I always look at the simple solution first before I go into the more complex solutions. I'll talk to you about a patient that kind of gets me in a little bit. Also, if we're thinking there's a systemic or a neuro issue, in my clinic, when in doubt, we refer it out. Let the experts figure that out. That's not up to me to tell you you have mast cell or Chiari or whatever. It's my job to send them to the proper people who are much smarter than me that know that stuff. And finally, our philosophy is if a patient can fix it, teach them to fix it themselves. It's a chronic disease. We need to actually have them be involved in their treatment. First thing we look at is SI joint, low back, and hip pain. All right. The SI joint, almost all EDS patients have an issue with their SI joint, and if untreated, it can cause hip, knee, foot, back, neck, and shoulder pain. The problem with the SI joint is that there's no muscle that crosses the SI joint. It's only ligamentous in nature, and it only has passive movement here. When we look at actually a person with EDS and we say, well, why does their SI joint go out? I always look at ground reaction forces first. So when a person walks, the ground reaction force from the foot, knee, ankle, hip up to the SI is about 3 times their body weight. When they run or jump, it's up to 10 times their body weight. And that's just physics. There's nothing we can do about that. So when patients say, can I go for a run? I'll be like, well, that's 10 times your body weight. If I threw 1,000 pounds on your back and told you to walk around, would you be happy about that? Probably not. So again, I try to use a lot of biomechanics and physics to explain why they can't do things. Because these guys are going to try to do things, and you have to explain to them why. They're big why people. So what do we do here? We actually do a lot of things with the SI joint. We always start here. We do muscle energy techniques, which are done. And we teach family members these techniques. I think it's very important. It's very difficult to hurt a patient's SI joint. So we teach the family members how to do this at home. They come in, we videotape it on their phone in the exact order that they have to do. They listen to my big mouth explain it. Then I have their actual spouse or whoever is going to be there actually physically do it with them so they have success with me that day. And that's an entire treatment session that we do, is just teaching somebody how to do that. We work on core, hip strengthening, postural education, and also ADL education, such as don't run. The other thing is when we look at low back pain, again, we look at other things that are non-EDS. They can have facet joint pathology, bulging disc, hypermobility, spondylolisthesis, muscle spasms due to SI joint dysfunction. We've got to make sure that they're clear of all the neuro and systemic issues. So again, when we have EDS and they have pain, you know, we quickly go to that EDS problem where they could just have a bulging disc. And we got to kind of look at that stuff too, because just because you have EDS doesn't mean you can't just have normal orthopedic problems. And then we talk about things that run the show. So when I talk about things that run the show with all my patients, I split the body into 3 sections, and each section has a joint that runs the show. In this pot, it's the hip. All right? What I mean by that is if you don't fix the hip, the SI joint and the low back pain will not get better. All right? So we're looking at the hip, we're looking at labral tears, but also in this population, we're also looking at instability of the hip. And I know a lot of EDS people are not going to like me right now, but I'm going to tell you, usually the hip doesn't dislocate or sublux that much. I have not seen that a lot. But what it does is it translates in the joint forward. And when it does, the femoral head can actually push on the acetabulum. This is usually due to the increased lordosis that they have in standing and tightness of the psoas in the quad. And when it rubs, it hurts like heck. So don't think just because it's not dislocated, it doesn't hurt. It hurts a lot. We've developed a bunch of muscle energy techniques on how to put that back into the system and work on psoas and quad stretching or myofascial release to those areas to keep it there. But we have to work on their posture because that's the thing that does it. But if we don't do that, again, it'll have some problems down the line. The other thing we work on, and Trish talks about this a lot with proprioception, is a thing called slow walking for the hip. Because what I find is these people with unstable hips, they don't have the muscular coordination to hold the hip in the socket during stance phase. They'll have increased Trendelenburg gait, they'll be kind of walking all over the place. We need to actually teach them how to do that. And we need to slow that pace down so they can learn it before we actually quicken that pace up. Common neck, mid-back, shoulder issues. Almost every EDS patient that comes has a neck issue. And I'm going to talk about the biomechanics of it. I did a whole hour-and-a-half lecture at the National Chiari about this. I'm just going to give you a quick thing. The take-home message here is the shoulder runs the show here. The shoulder usually subluxes anterior or posterior, some do posterior, but its sublux is inferior. So it's hanging out of the socket. And that was actually kind of demonstrated to me by one of my patients 6 years ago. She was actually subluxing anterior and posterior. It didn't make sense that that would do that biomechanically. And again, in the EDS population, it has to make sense biomechanically. It just, in my mind, that's what it has to do. So we figured out that it actually subluxes down. So we do a taping technique with a thing called leukotape, and we physically push the shoulder back into the socket and we tape it there. The thing that we do is in our evaluation, this is the first thing we do, all right? And we're looking to see what kind of shoulder instability, how much neck pain is it. I've had patients with EDS come to me with neck pain for years. I tape their shoulders and all their neck pain's gone, all right? For the most part, that doesn't happen, all right? For the most part, what is they'll come in with like a 8 out of 10 pain, we'll tape their shoulders, it'll go down to a 3 or a 2, and we'll say, okay, the shoulder has a certain amount, but there's other things involved. I also talk about it's a major issue to strengthen this before tethered cord, Chiari, and CCI surgery. If that shoulder's unstable, it makes it pretty bad for us to get it done. I also always tape the shoulders before tethered cord surgery just to make sure that there's no issues post-op. We'll just quickly go through posture. And again, increased lumbar lordosis, thoracic kyphosis. You can actually see her hips actually going anterior right now. The head weighs about 12 pounds. Every inch forward the head is actually an extra 10 pounds of weight on their cervical spine. And this is a patient that has not gone through my protocol yet, and we taped one that just finished my protocol. You can see the difference in the posture, working on the strengthening in the posture before my protocol and after. Neck pain, again, look at bulging discs. Dr. Chopra talked about first and second rib can cause scalene tightness, looking for thoracic outlet syndrome. The only thing I talk about with neck pain, make sure biomechanically you look at it from T7 all the way up to C1 as well as the ribs. All of that can cause neck pain. I just did a little thing for you guys for the facet joint pathology and the referred pain for the facet joints. Always look for CCI and Chiari and tethered cord. We'll always treat this with posture exercises, muscle energy, indirect techniques, cranial sacral. And then finally, we'll talk about the foot and the knee. I got 3 minutes, I'm doing pretty good. In this one, the foot runs the show. The foot is usually flat or pronated with the navicular and the cuboid splayed. They need orthotics to control this pronation. When you have pronation in the foot, and Dr. Chopra talked about this before, you'll have an increased valgus stress at the knee. When you have an increased valgus stress at the knee, you're going to have the tibia will externally rotate and the fibula will laterally flex. This can cause an impingement in the peroneal nerve that lies just posterior to the fibula head. Also, when we're looking at EDS patients that actually have knees that sublux, remember the patella is just a sesamoid bone that's embedded in the patella tendon. So if the tibia tuberosity actually goes laterally, that'll take the patella with it. So just by taping the patella is not the total thing that'll help these people. We have to work on the knee and the foot. And again, I just said what we do. And this is a taping technique that we use. It's a mulligan taping technique to help stabilize the fibula and the tibia while they're walking. And finally, I just tell everybody we like to treat people, not the dysfunction. These people are here, they have chronic pain, but just because they have chronic pain doesn't mean they have dreams or aspirations. This is one of my patients who just graduated a year and a half ago now, wow, from PC, tops in her class. She actually went to DC to go to grad school. We actually took a road trip out to DC to talk to her PT to make sure it was okay. It was the first time she's ever been away from home. And finally, that's my family. It's my wife who actually runs our North Smithfield clinic. She treats all of our EDS patients there, and my son. And if it's not for their understanding, I wouldn't be able to come here and talk to you guys and waste 20 minutes of your life. And thank you.